ones which are non-modifiable. If one of the modifiable factors is obesity, someone who's big, weight yomuntu, you're going to have an increased body weight. I get by which that weight is going to contribute to a force on the knee joint. Are you getting it? So you can modify that risk factor and you change, and you may get healed. There is also joint trauma, whereby maybe it's an accident, maybe there is repetitive injury to the joint. All those ones are modifiable risk factors that you can. Modifiable means you can easily take away that risk factor and you get some significant improvement, or actually you can heal. Are you getting it? Then the non-modifiable ones, we have advancing age. The more you age, you can't modify that risk factor. The more you age, the higher the risk of you developing osteoarthritis. Sex, also genetics, are you getting it? And the joint location, that's how we have. So the development of symptomatic osteoarthritis occurs with advanced age, dominantly on weight-bearing knees. So in women, it can be affected by localized inflammation of the proximal and digital interphalangeal joints, known as Burchard and Heberden's nodes. Those are, if you look at our fingers, or joints, so connecting our fingers, are you getting it? Those joints, they are called interphalangeal. So we can have Burchard and Heberden's nodes. There's a difference in them. I think you can read about the difference between Burchard and Heberden. It is different because one is on the first joint, one is on the second joint. Are you getting it? They have talked about interleukin concentrations that have been associated with the destruction of the articular cartilage. They have talked about joint trauma that can cause osteoarthritis. Biochemical and mechanical changes can occur, resulting into joint pain and stiffness. Results are articular cartilage, the joint capsule, and the subchondral bone. I didn't get I think we would have got the structure of a joint for you to know where these parts are located. It would have been easier. It would have been very easy. Actually, I shared it with Emma, the structure of a joint. You need to appreciate where the cartilage is located. That resilient tissue that covers the ends of the bone. It acts as a cushion. You need to have known where the ligament is, that one which connects a bone to another, the tendon which is connecting a muscle to a bone, the synovial fluid, that fluid in between the joint. The moment you leave the cartilage, then in between there, that liquid is called the synovial fluid. Inside there, we have got the joint capsule, the basal. All those ones can be affected in these conditions. So they talked about regular exercise and physical exercise don't increase the risk of osteoarthritis in normal joints and are necessary to maintain the cartilage. If we can go down and talk about the pathogenesis, they have talked about it. You need to have known repetitive traumatic injury to the articular surfaces initiates a cascade leading to inflammatory cytokines, mainly the tumor necrosis factor and the interleukin-1. Those are inflammatory mediators and what? Those inflammatory cytokines, and that's our target. That's why we shall appreciate some drugs coming in to help us. Nitric oxide, enzyme that break down the extracellular matrix, all those ones. So I'm not going to read through the pathogenesis. You have heard about osteophytes, the bone outgrowths that are produced by the chondrocytes in case it cannot easily repair the cartilage, so that they produce that to act as a shock absorber in case, but it is the one producing the pain, those bone outgrowths that we have. I had someone talking about the cyst formations, subcondocytes. You have to know about them. I'm not going to talk about it. Calcium deposits. So this is generally how a bone looks like. A healthy joint looks like that. You can see the articular cartilage. Are you getting it? That shock absorber. It minimizes friction during movement. Are you getting it? We need it to be there between those joints. You can see the meniscus. It's also part of the cartilage that acts as a shock absorber and improves joint stability. You can see the normal joint space. There is space in between there. And in between there, we normally have what we call the synovial fluid, which is always there. So in damage, you can see how it is. Have you seen the bone spurs? Bone spurs are the same as the osteophytes that are produced by the chondrocytes. Are you getting it? In case it fails to repair the cartilage, you can see that the cartilage is being damaged. Maybe because of repetitive injury. Maybe we talked about the other causes that we talked about, acromegaly, trauma, what. So remember, the matrix of the cartilage consists of it has the chondrocytes. So if they fail to repair it in time, they start producing the bony spurs, and those are the bony outgrowths that you see. That those are the sources of the pain that we have, and they are the ones responsible for producing that crackling sound. Omuntu ajja kujja agambe joints zange zinnuma, joint ennuma ate mpulyamu sound evaamu mpola mpola. Okitegeera, that crackling sound is because the reduced joint space we have there and the cartilage being lost. Are you getting it? And the bones are crashing on themselves, friction. Are you getting it? But especially those bony spurs. Are you getting it? So when someone does an X-ray, you see we have a normal joint knee joint, sorry. You can see it, even you can see the joint space, it is there. But when someone has osteoarthritis, you can see the space, joint space has been reduced. You can, if you can compare, you will see that there's a significance in these joints. The joint space is one of the what that tells us that actually there is either osteoarthritis or other forms of arthritis. So that's how we differentiate if we do an X-ray. I've taken more pictures to show you a healthy femur bone, healthy articular cartilage, tibia bone, bichi, but you can see something which is degenerating, the cartilage degenerating. A sparring femur bone. Sparring means those osteophytes being produced, the bone spurs, they are coming from the chondrocytes that are within the matrix of the cartilage. You should know the composition of the cartilage. It has chondrocytes, which are specialized cells that maintain the cartilage matrix. Remember, the cartilage has collagen and the glycosaminoglycans, the chondroitin sulfate. I think down there I'm going to show you the brands we have at Zest that contain those supplements. Are you getting it? Yeah, they just contribute to the lubricating properties of the cartilage that are there. We are going to look at them down there. So that's how it is. That's how osteoarthritis comes. Are you getting it? So our goal, let me go to drugs. Our goal of therapy is to provide analgesia to support activities of daily living. Someone here has to be able to participate in occupational therapies and physical therapies. Are you getting it? The initial treatment, most of them, they talk about if someone has come is for the first time. Awuliramu joint muluma okitegeera. At least it's unilateral. Again, you have to be able to differentiate osteoarthritis, rheumatoid arthritis, polyarthritis. Are you getting it? For rheumatoid, many joints are involved in. Are you getting it? Joints of gallo, joints and knees, joints zawa. Are you getting it? But in most cases, you may find that in osteoarthritis, it is one joint, it is two joints. Maybe it's the hip joint, maybe it's the knee joint. Maybe it can combine the hip, knee joint, something like that, but not overall most of the joints. Are you getting it? So that's one of the differentiating factors that we first have to look at, but doesn't make you to rule out. You have to further go and do tests to know which type of arthritis someone has. For the back pain, we talked about ankylosing spondylitis, which is also the same. We shall see the same management that mainly affects the spine. Those are people who walk with a stooped posture. If you look at them, someone who always complain of back pain, you may see the posture a little bit changing. You have to encourage this patient to go and do an X-ray. They look at the what? And the vertebrae. So initial treatment is acetaminophen for 2 to 3 weeks in doses of 4 grams per day. Your Panadol. If it's for the first time the patient is arriving, omwa Panadol. Okitegeera nasooka amirako. Elders above 65 years, unless clinically contraindicated. For above 65 years, they give like 3 grams per day. That is 2 times 3. because each has 500 milligrams. So that is to 1 gram, like the normal way you give it. But at least for these ones, healthy ones, you give like 2 times 4 of acetaminophen. But we are going to more down look, see how well we can use these NSAIDs, the acetaminophen, the tramadol, and how can we use other intervention in case we find this patient has maybe other conditions like cardiovascular, blood pressure, kidney problem, liver problems. How can we intertwine the paracetamol, the NSAIDs, the celecoxib, the what? How can we? Because we don't just bombard. We have to take enough history. So the NSAIDs have a better efficacy because of the significant anti-inflammatory effects than acetaminophen, especially in patients who present with pain and inflammation. That is it. Someone may come when the joint is paining, but there are no signs of inflammation. Are you getting it? It's hard because for me, what I base on for inflammation of what no did most times an inflamed part is normally hot. I don't know if I'm lying. Watera okwokyereramu katono hot omukwatira wawookya oba omubuuza wennyini bw'olyanga ewookya owulira kitegeera. So there it can help you to know whether I can give acetaminophen or a real NSAID, because acetaminophen doesn't have anti-inflammatory property. It only has analgesic property. It only takes away the pain. But for NSAIDs, they combine both properties, which may help. Are you getting it? So patient education prompting the consumer and healthy professional awareness to potential liver injury. So what and some more acetaminophen, jukira you are giving these patients these drugs for a long time. It's not that ogenaba like the way you give normal painkillers for like over 1 week. No, these are things whereby omuntu agenda kubeerako for a long time. Tebitera kuwona bino by arthritis. Very hard, especially rheumatoid arthritis. For osteo, significant improvement may be there, but most of it, in most cases, it is reversible. Are you getting it? So you have to know that you are going to maintain these patients on these drugs for some time. So you have to take enough concrete history to know that if I decided to give this type of painkiller, how long do I give it? Are you getting it? Or what are the monitoring parameters should I go through while monitoring this patient while this patient is on this particular type of drug? So you may find that this patient has a liver problem. Are you getting it? Having a liver problem. Are you going to give acetaminophen? We all know the side effect of acetaminophen on someone who's having a liver problem. So you have to switch to an NSAID. But someone, what if he's having ulcers or he's having a history of GI bleeding? Do you give an NSAID? Or if I give an NSAID, do I add on a PPI? Are you getting it? If I sagala kwa NSAID, sagala kwa acetaminophen, let me give tramadol. Are you getting it? But someone may have history of seizures. So just imagine, patient comes, ayina ulcers, ayina ebirwadde eby'omutima oba heart failure aba ayina ki, ayinamu obuzibu bwa liver, ayinamu obuzibu bwa kidney. Kwegamba, it's hard to choose for that client some medication that will be able to. Okay, it is very hard because you have to keep monitoring that patient because you know more, the pain has to go away. And at the same time, you know the side effects of these drugs on those particular conditions. So you have to be careful when you are choosing these drugs. So, but we shall sit down there. We have to carefully assess to weigh the risk and benefit analysis, like adverse events like GI bleeding, diminishing renal function. Remember, if you have decided to give an NSAID, you have to rule out the history of GI bleeding. Or if you don't, you add on a PPI. So more naproxen. I normally love naproxen. Is what I give in these arthritic conditions. But if there is a history of GI bleeding, you can add on a PPI. If you have decided to take that path, because everyone has different way he reads his books. If you have decided to take, you can add on a PPI.